Okay, so we are very lucky to be able to sit down with Dr. Katie Pohlman, who is going to be explaining to us her systematic review, which has just come out, which is manual therapy in pediatrics. Doc, thank you so much for taking the time to speak to us.
Thank you for having me. I'm very excited to be sharing this publication with everyone.
It's the wonder of technology. We get to be able to talk to each other across vast distances.
Absolutely.
It's wonderful. So the paper that you put together comes out at a phenomenal time for manual therapy, especially in pediatrics, because we're looking for evidence. And I think as clinicians, we want to know, where are we in this situation? And I think the level of research that you produced allows us to be able to explore that properly. So can you just take us through the systematic review that you put us through?
Absolutely, and thanks for that awareness. This paper was what I wanted to see 10 years ago when I first went into chiropractic in the pediatric field. I just wanted somebody to say where we were at in evidence, and it was shambled. Look at this, look at that. And so this was something I had wanted years ago, so I really made this for it to be easy for a clinician to take and understand where we are at evidence-wise at the moment. And so I appreciate that you're excited about it as well, because it was 10 years in the making of it in my head of what I wanted, and I'm glad other people wanted it too. and so the systematic piece of this was that you can have lots of different types of reviews, and all of the reviews have purposes. I wanted to do a systematic in that it pulled everything together, not just pieces that you liked or didn't like, or pieces that were low quality or high quality. I think they all have a place in us helping to understand. And then in the paper, we try to lay out every piece of it so that you as a clinician can take the overview, but you can also break it down to the little as nitty gritty as you want. That information is in this one paper. You don't have to, you can get the original out if you want to, but it's all in this one document.
Cool.
So that was the systematic piece of it. Make it as thorough as possible. I was really excited about having on this is that I made sure that we had practitioners on the team of scientists, because I wanted it to, I haven't practiced in years now, and that's what I really wanted it to be able to be understood and used by clinicians. And so I made sure on the authorship team we have two practicing clinicians on it.
Wonderful. And I suppose that's so good, because you as a clinical scientist gets to be able to orchestrate, and then we have the practitioners on the ground being able to say, this is what's happening, this is what people in my position are looking for.
Exactly. It was a beautiful combination.
Cool. And this paper looks at, you look at outcomes, but you also look at like the methodology that the people used, and you go, was it a good way of looking at the outcome? And then we kind of rate it like that, and going, yeah, there was an outcome, but was there bias? You look at it in those kind of terms to be able to really get the actual outcome.
Yeah, and one of the big problems with doing research in chiropractic or in manual therapies, and especially in children, is that effectiveness, the gold standard is this randomized controlled trial. And so we actually don't have a lot of them. I don't remember numbers, and so that's why I do have this in front of me, but I forget how many were exactly RCTs. But I included observational data because the more sophisticated the observational data, the closer to eliminating all those biases that make it as close to an RCT as we can. So I think observational data is more useful if it's done right and if it's done well, which is why I chose to include it, although people can criticize that you can't find causation on observation. That's an epidemiological issue, but I left them in there, and somebody else, you can choose or choose to ignore or choose to include in the thought, which is why we kept it all in there.
I suppose because you're looking for, as a clinician, I suppose from my personal experience, I am looking for real world data. It does help me to have that, but then I have to go, how generalizable is that exact one to my situation? And I suppose you have to be able to run that through in your head to be able to get the outcome.
Exactly. So observational data, I've always said, I think we realized in our profession that, oh no, we don't have any data. Jump right to the RCT.
Yeah.
However, we observational data is so needed and so valuable in that it tells us what we need to control in a randomized control study and what we need to be evaluating. And I don't think we've spent enough time in that observational world trying to figure out what's going on in your office, because there's incredible stuff going on in the offices, but we just jumped right to this randomized control trial and not figured out the correct pieces, which is another reason why I think including observational data is important.
Okay, I get you. Now, one of the interesting things about this trial is that you were looking at manual therapy as like a banner, and within that we had chiropractic manual, well, you had spinal manipulative therapy, osteopathic treatment, chiropractic manipulative therapy, craniosacral. You kind of went all over to be able to, what was the purpose to get all of those modalities in?
Yeah, thank you for that question. And so when somebody says systematic, it's systematic. You try to get as thorough and complete as possible. And a lot of our manual therapies do overlap. And that was the reason why we decided to include any manual therapy, because we do feel that they overlap. However, we tried to be as clear as possible in the paper so that, again, the reader, somebody trying to see how applicable it is to their practice or their situation, they can whittle that out and decide for themselves whether it applies or doesn't apply.
Wonderful.
But again, we wanted it as thorough as possible.
Another tool for your kit inside there.
Yeah. Absolutely,
Okay.
absolutely.
So I am just dying to have you run us through this paper. So let's get going.
Thank you so much for that opportunity, because I was so excited to have this paper and something useful for a clinician to use. And then when it all gets done, it's 38 pages. I'm like, I don't have time for 38 pages, right? So you're going to read the abstract and then, put it down. At least I would, until you get that free moment, which is never going to happen.
Well, I tell
so
you what, you lit up the brains of probably a good couple of nerds all over the world, where we saw it on Pubmed and we went and devoured it. So I think it's let's allow the nerds to just give that information.
Yes, I will break it down to exactly where you need to start with. So with any paper, when I go to read it, of course I do read the abstract first to make sure it's applicable. Yeah. But I always start with the tables, and that's what I did here, or that's what the authors and I did here. And so I think the best place to start is with table number 3.
Perfect.
So I'll hold it up like everybody can see it.
Oh, and what we'll do is we'll put these in the notes of the podcast. We'll put these in the show notes so people will be able to get this.
And I was really excited to have it published in an open access journal. That was like mandatory for this paper, so that everybody can get access to it.
Yeah, that is so important. You can go right to PubMed, you can go and download it, you can have all of this right on your computer.
That was a huge component.
Yeah.
To this publication. With that, so table 3 has the overall summaries of the whole paper, and we broke it down by clinical conditions. We broke it into 5 components: GI, musculoskeletal, respiratory, special needs, and then structural conditions. Yeah. And then within there, every condition that fell in those parts. Before this paper came out, I have 4 papers as a pediatric chiropractor. I think four papers everybody should know. And before this paper came out, it was the Claire et al. Manuscript. Yeah. The only difficulty I had with that was that you really had that included adult populations, and so you had to spend a lot of time whittling. And I had made a version with highlights, and that I would distribute to people to try to make it easier. And so that was another thing, is to update her piece.
Yeah.
And then I did a comparison. So in this table, it says how her paper came out in 2014. So any changes from 2014, and then it includes the number of studies and the type. So RCT versus observational. It includes the intervention. It has the citations. It includes the quality assessment. So that's a paper cannot be called a systematic review unless it has some quality assessment, because garbage in is garbage out. And so you want to know the quality of it. And so we've rated the quality. We've given the overall quality, the sample size, because how many people are in a study can make a big difference. Sure. The results of the study, which we broke down to improvement, no improvement, or no difference between the groups that were being studied. And then for each condition, we gave some sort of overall summary. Okay. And that piece, we had lots of discussions of whether that was valid or not, because within each piece, like we said, some of the techniques were different. Some of the what they were observing were different. So in asthma, you can do quality of life, you can do respiratory rates or conditions, and with those, you're paring it down. However, because I wanted it to be very very easy for somebody to know where we're at right now. I was very, so these are going to be as, what's the word? I apologize that I'm conservative. That's the word I'm looking. These are as conservative. These are the most that we can do. Now, if you break it down into a study, you might be able to come up with different conclusions than these conservative findings. Mm-hmm. But I really wanted like a take home and give us places to grow. Good. And so that's table number 3, and it really breaks down all of the conditions that we have. Table 4 and 5 then go into the quality rating. And again, those are they have to be in if somebody's calling themselves a systematic review. And we broke down how we rated things, but you might be able to differ. Maybe we were wrong. You know, we had a lot of authors, we did a lot of double checks, but you can always be wrong. And so that's why we thought this table would be awesome, so that you can see what we did and you can yourself agree or disagree. And even though a study may be low, the things that we rated them on may not affect your outcomes. Like, you know what, that is low. Yeah. However, I don't think that impacts the way I need to interpret the study. So it gives people that ability to change, to look at their scenario and see how it impacts. So you
as a clinician, you get to interpret this for your practice.
Yep. You can break it down. So table 4 breaks down all the randomized controlled trials, and then because we use different criteria because of the 2 different designs, table 5 breaks down the observational studies. And then tables 6, 7, 8, 9, and 10 break down every single paper into and breaks it down by the GI, the musculoskeletal, the respiratory, and extracts the data for you. And so again, with that, we have the study objective, the sample size, the study design, the intervention, patient description, so exactly who they included, because pediatrics, while we included 18 years or younger, that's still a huge gamut, right? Yeah. The primary outcome, the main results, and then any adverse events. Okay. And so somebody can dive as deep as they want or stay as on top as they want or need for their situation. And that was the goal of the paper. And then the text just breaks all the tables into a descriptive manner, but we broke it down each section by there. But the tables really lay it out and hopefully make it easy for a clinician to use. And again, that was a big
interesting is the word. That's where because you have a look at the table, then you're like, okay, I need to see this. How did this go down? And then it's all there in the text for you, which is wonderful.
Exactly. You don't have to look at Pubmed and be like, where do I begin? You can begin with this and go as deep down in that rabbit hole as you want to go.
That's true. Yeah.
You know what? Can I give you my big take homes?
Please.
That I got from it number 1, I think surprising to me was in the Claire et al. Paper, one of the things I used to say was that there was no, and she only did RCTs, but there was no evidence. She did not include any pediatric musculoskeletal condition in her paper. And when it comes to like what are kids using, all of the survey data, kids are coming to us for musculoskeletal conditions, and yet we had 0 in prior systematic reviews. The amazing thing in the study, we now have not just some things on musculoskeletal, but some really high quality pieces on musculoskeletal conditions, and from the chiropractic perspective. I think that's just wonderful to take as the big. I'm like, yes, because every time I'm like, guys, we don't have anything on this, and now we can clearly say we have some good quality evidence, and that's one that I have as we found to be moderate favorable low back pain in the adolescent population. The other disappointing but thing that I found was our different professions. All right, so when I broke it down to the different professions or the different techniques that were being used, the osteopathic manipulative therapy has a ton more literature than we do. And when it comes to, so I dug into that a little bit more to figure out why. And at the end of the day, it's their profession is funding the studies to be done.
Yeah.
And I think in our profession, it's something we haven't contributed a lot of funds to. And unfortunately, as a scientist, it's not something national funds. When it comes to all their priorities, cancer and AIDS, this isn't on their high priority list to give money to. So if it's something we want to increase, I think we need to model after professions that are producing a lot of literature.
Where does this paper take us? That I think is a really interesting thing. Where do we go to as practitioners? Number one, let's start with this. How can we help? What kind of data do we need to be keeping to move it along?
So when I started this paper, that's what I love about the scientific process. As systematic as it is and as rigorous as it is, it's also an art that if you let it just go, it's like writing a story. The story evolves. And so the story behind this actually started 2 points is that I had wanted a document like this for a long time, but the other piece is people would come to me and say, what outcome measures should I be collecting in my practice that could be useful to you? And I struggled with that. So I actually started this systematic review so I could see what measures were being done in clinical trials to see if they could be done in practices. And so that paper is coming out. We're finishing the analysis of that because we had to do collecting the data, and then we just went off on this paper. But the other piece of it, looking at the outcomes that we can be using, but I'm going to, the highlight of that is I was surprised with how little there was. And so we're really at the drawing board of what outcome measures should we really be collecting. But we do have, so I don't have an answer to that piece, but that was something that came from this with the desire. Okay, we have all these gaps. We see where we need to go. Now, how do we get there? Because outcome measures are, what outcome measures do you use to measure these things is important. And that's actually a hole that we have to even begin this process. But I think musculoskeletal conditions and Denmark are doing amazing things. Watch out for Lisa Hesbeck's the work that she's producing in that area, and I think she's gotten musculoskeletal conditions. I think we need to put a lot more focus in those areas, which will allow more people to come into our doors, which will allow us to gather evidence, because the outcome measures for all other conditions are so sporadic and all over the map and not validated and not reliable. So we need to spend work coming up with the outcome measures while looking at a condition that we're likely really good at and has outcome measures.
Yeah. One thing I would like to ask you, because people are going to read through the paper and they're going to see that you come out to either good evidence, moderate evidence, and then you come out to inconclusive, favorable, inconclusive, unclear, and unfavorable. When you have an outcome like that, let's say I'm a practitioner and I'm looking to treat whatever condition is on there, and I look through and I see, I've got inconclusive favorable. What am I looking at? Where am I aiming?
So when you come to the practitioner, when it comes to treating a patient specifically?
Yeah, so if they get someone that comes in with otitis or something like that, and then they look through the paper and they go, what is the evidence I have? And it comes out, let's just say, for instance, it comes out inconclusive favorable. Where are we sitting?
Yeah, and so I think that's an excellent take-home message of this paper, and it's setting patients up with clear expectations. Here we in the evidence, there is it has not been shown to be effective. However, clinical experience in some trials that didn't have all the, it's hard for me to speak patients, but that didn't necessarily have all the rigor that's needed, has shown favorable results. And so I think it's worth a trial of care for your child. And I think just setting up clear expectations, not promising a cure, not promising, things that we haven't shown in the literature, but just speaking to a patient with the expectations. However, I've had the clinical experience, or my instructors have had the clinical experience. The patient is in your office, so that the patient has a desire to be there. And then just bringing in that evidence piece is just giving them the clear expectation of, I think a trial of care is warranted. If we do X, Y, and Z and we don't have an outcome, be on your way. And I think that's a fair way to present this data to patients.
I really love that, simply because I feel we're always in this position of having kind of our heads put down to the ground going, you don't have evidence, where we do. And it is in that realm of grey where a lot of things tend to be. I mean, I was listening to a keynote address about hip dysplasia, and they were talking about public harness, and right at the end they said, look, we don't have great data, but it's what we use.
Yes.
And okay, hang on a second. This is a lot of the time how it works is the empirical data as one pillar, your clinical experience as another pillar, and then patient expectation of outcome as another pillar, to be able to go, okay, now we put these three things together, now we can move forward. Is it absolutely evident? Well, it's where it is, and as long as I'm honest about what the evidence is and where it is, and a trial of care, it can be warranted with this, because again, we can show that relative lack of adverse event, and be able to say, look, efficacy versus adverse event, put those two together and go, trial of care. But be able to get that boot off our head saying, you have no evidence. It is there. But at the moment, it's,
that's exactly what we need to do as clinicians. Own where we are at, accept it. We're not the only profession, everybody in this field, we don't have evidence for everything that goes on in the healthcare profession, but owning it, being able to clearly describe where we are at, and bring it into the whole picture of the patient's desire and your experience is exactly where we need, I think, where EBP, the evidence-based practice, needs to be.
So, Dr. Katie Pohlman, thank you so much for hanging out with us, and thank you so much for just digging into the paper, what it means, and how as clinicians we get to use your hard work.
Awesome. Thank you for the opportunity. And I also got to witness the South African sunset. So that it was dual lovely. So thank you for the opportunity. I look forward to seeing where this paper goes and where our profession, how we grow.
Wonderful. Thank you so much.